we discussed that inguinal hernia, in indirect inguinal hernia, the neck of sac is above and medial to pubic tubercle, and in femoral hernia, the neck of sac is below and lateral to pubic tubercle. So we are going to discuss the femoral hernia. Femoral hernia. There are two important points related to femoral hernia. Okay, very important. First important point, what is the most common type of hernia in females? And we discussed that in both males and females, the most common type of hernia is indirect inguinal. And you know, femoral hernia is more common in females. So first important point, femoral hernia, it is more common in females. More common in females. But most common type of hernia in males and females is indirect inguinal hernia. Generally, femoral hernia is on right side and it's bilateral. It is more common on right side and it's bilateral in 20% cases. It is more common in multipara patients. Generally, you will see that most of the hernias are more common in multipara. Why? Because you know that during pregnancy, there is release of one hormone, relaxin, and this relaxing is going to cause the laxity in the ligaments. And because of this laxity, what's the problem? There is increased risk of hernia. So it is more common in multipara patients. Multipara patients. Clear? And generally, we should not use truss. So truss should not be used. In femoral hernia, the truss should not be used. Clear? Now see, the important points related to anatomy of femoral canal, femoral ring and femoral hernia. Now first important point, what is the diameter of femoral ring? The diameter of femoral ring is 1.25 centimeter. And what is the length of femoral canal? That is also 1.25 centimeter. So see, diameter of femoral ring. This is 1.25 centimeter. And length of femoral canal. Length of femoral canal, that is also 1.25 centimeter. Okay, so answer is same and it is 1.25 centimeter. Now see here, if you notice, see, this is the femoral ring and this is the femoral canal. Clear? So what you can see here, that it's narrow and it's very rigid. And see what are the structures which are in relation. So this is femoral ring, femoral canal, and here you can see this is femoral vein, this is femoral artery, and this is femoral nerve. So from medial to lateral, if you see the relation, it's van. So there is femoral canal, and from medial to lateral it is van, femoral vein, femoral artery, femoral nerve. And if you see in the femoral canal, there is a lymph node. Can you see this green colored lymph node? And what is the name of this lymph node? This is known as Cloquet lymph node. So very important point. It is asked in exams also. The name of this lymph node is Cloquet. Okay, so lymph node is Cloquet. From medial to lateral, the relationship is femoral vein, femoral artery, femoral nerve. Now the problem, since the canal is very narrow and rigid, whenever there is herniation or patient is having femoral hernia, there is high risk of strangulation. And because of high risk of strangulation, the surgery should be performed as early as possible after diagnosis. So can you see here? This is the bowel which is herniated in this femoral canal. Since it's narrow and very rigid, so what is the problem? There is high risk of strangulation. So second problem, femoral canal. Femoral canal. It's narrow and rigid. Narrow and rigid. And because of this, there is high risk of strangulation. Increased risk of strangulation. So whenever these patients are coming to our OPD, generally we admit. And in the coming OT, we perform the surgery. So surgery should be performed as early as possible. Now see what are the named surgeries which are asked in relation to femoral hernia. So see, this structure is inguinal ligament. Okay, so if we give inguinal incision, that is known as inguinal approach, it is known as Lothian. If it is infrainguinal or subinguinal, also known as low approach, So subinguinal incision is given in Lockwood, inguinal incision is given in Lothian, and suprainguinal incision, this is also known as high approach. So suprainguinal incision is given in McEvedy. So how to remember? You should remember from below upwards: Lockwood, Lothian, McEvedy, subinguinal, inguinal, suprainguinal. Clear? So these are the three incisions which are given, three approaches for the patients of femoral hernia. So these are the commonly asked questions. But what is the treatment of choice? This is not the treatment of choice. Treatment of choice for femoral hernia is Henry's procedure. So these are the approaches which are asked, but if we are asking the treatment of choice, it's the Henry's procedure. Clear? So in Henry's procedure, what we perform? It's the midline, extraperitoneal, femoral hernioplasty. Okay, so this is how we treat the patients of femoral hernia. After that, there are variants of femoral hernia which are frequently asked in exam. One is Logier's, second is Cloquet, and third is Nareth. See, what are these types? In this diagram, if you see the relation, this is femoral vein, this is femoral artery, and this is nerve. So vein, artery, nerve. And what is this hernia? This is the typical femoral hernia. Clear? Now see the variants. If you see, first variant is the Logier's hernia. And here what is the problem? There is hernia through gap in the lacunar ligament. Can you see? This is the lacunar ligament. So you can notice that there is hernia through gap in lacunar ligament. So this is Logier's. How to remember? L for L. So Logier's hernia, L, there is gap in lacunar ligament. Okay. So what is this Logier's hernia? It is hernia through gap. Hernia through gap in lacunar ligament. So hernia through gap in lacunar ligament. Okay. Second, there is hernia behind pectineus fascia. And if, can you see, this is the muscle pectineus. So whenever there is hernia behind pectineus fascia, this is known as Cloquet hernia. So what is this Cloquet hernia? This is hernia behind pectineus fascia. So it is hernia behind pectineus fascia. Okay. And you must have studied congenital dislocation of hip in ortho. So whenever there is congenital dislocation of hip, what's the problem? There is lateral displacement of sac of femoral hernia. And whenever there is lateral displacement of sac of femoral hernia, this sac will come in relation to femoral vessels, and this is known as Nareth hernia. So Nareth hernia is seen in which patients? The patients of congenital dislocation of hip. And what is the relation? It comes behind the femoral vessels. So first was Logier's, second was Cloquet, and third is Nareth hernia. Nareth hernia. So this Nareth hernia, it is seen in the patients of congenital dislocation of hip. And in this case, there is lateral displacement of sac. And because of this lateral displacement of sac, here the sac is located behind femoral vessels. So in Nareth hernia, sac is located behind femoral vessels. It's located behind femoral vessels. Clear? So these are the variants of femoral hernia. Now we are going to discuss Spigelian hernia. So what is Spigelian hernia? In Spigelian hernia, there is hernia through Spigelian fascia. And what is the location of most of the hernias? Most of the hernias are located in infraumbilical region. Why? Because there is deficient posterior rectus sheath. And if you are talking about Spigelian hernia, most of the Spigelian hernias are located either at or below arcuate line. What is the location? At or below arcuate line. So see, Spigelian hernia, in this case, there is hernia through spigelian fascia. It's the hernia through spigelian fascia. And what's the location? It's infraumbilical. And where exactly? In infraumbilical region. Where exactly? In infraumbilical region. You have to remember it is located at or below arcuate line. This is important. At or below arcuate line. Clear? But what is the problem? In Bailey it's written that most of the spigelian hernias are located above arcuate line. That's a wrong statement. If we read Subiston, in that it is clearly mentioned that it is located at or below arcuate line. See, in Bailey it is written that in fact the defect is almost always above the arcuate line, and it is mentioned that spigelian hernia is located above the arcuate line. Now see what's written in Subiston. This is Bailey and this is Subiston. So what is written in Subiston? Almost all spigelian hernias occur at or below arcuate line. Clear? So there is no confusion. What is the location? It is located at or below arcuate line. Okay. Now see what is the exact location of spigelian fascia. And what is spigelian fascia? So if you see this diagram, you can notice that what is the name of this muscle? Yes, the name of this muscle is rectus abdominis. Clear? So this is rectus abdominis muscle. Now you can see there is semilunar line. So here you can see this is the semilunar line. Clear? So between the lateral border of rectus abdominis and semilunar line, there is a very thin aponeurosis. Can you see here? In this case, this area. Clear? So there is very thin aponeurosis between the lateral border of rectus abdominis and semilunar line. This is known as spigelian fascia. So whenever content is going to penetrate this spigelian fascia, and after penetrating the spigelian fascia, the content is also going to penetrate the internal oblique. What happens? The content comes between external oblique and internal oblique. So this is spigelian hernia. Now see the layers. This is external oblique. This is internal oblique. This is transversus abdominis. This is fascia transversalis. These are the 4 layers in abdominal wall. The content is going to penetrate the spigelian fascia, then internal oblique, and it is located between external oblique and internal oblique. Since it is located between internal and external oblique, it is also known as interparietal hernia. Second important point, since it is located behind external oblique, generally these swellings are neither visible nor palpable. Okay, so see the important points. So here we discussed what is the location of spigelian fascia. What is the medial boundary? Medially, there is lateral border of rectus abdominis, and laterally there is semilunar line. So laterally there is semilunar line. And in this picture you can see that this is external oblique aponeurosis, this is internal oblique, and here there is spigelian fascia. So it is going to penetrate the spigelian fascia, internal oblique, and then this spigelian hernia, it's located between external oblique and internal oblique. That's why what is the other name? It is also known as interparietal hernia. It is also known as interparietal hernia. And since it is located deep to external oblique, it is neither visible in majority of cases. It's neither visible nor palpable. So it's neither visible nor palpable. That's why these patients are not coming to us. So what is the problem? There is delay in diagnosis, and in majority of cases what can happen? Because of delay, there can be strangulation. So these patients have pain, and when they have pain, they come to us. Since the swelling is neither visible nor palpable, how we are going to make the diagnosis? This diagnosis is made by ultrasound or CT. Okay, so see the clinical presentation, clinical features. These patients present to us with abdominal pain. Why? Because there is delay in diagnosis, because swelling is neither visible nor palpable, and because of this there is increased risk of complication. So whenever there is complication, these patients come to us with abdominal pain. How we are going to make the diagnosis? So the diagnosis is made by, we discuss ultrasound and CT. We discussed that the diagnosis of hernia is purely clinical. Exceptions: internal hernia and Spigelian hernia. So when the diagnosis is done, we have to treat. And how we treat the Spigelian hernia? We reduce the herniated organ back. So herniated content is reduced back and we are going to close the defect. So what's the treatment? Treatment: reduce the herniated organ back. Reduce the herniated organ back. Clear? And close the defect. So reduce the herniated organ back and close the defect. Clear? So this is how we are going to manage the Spigelian hernia. Now see these hernia. What is the special features of these hernias? That here the posterior wall of sac is formed by the viscera. See, this is the anterior wall of sac. Clear? And here you can see the posterior wall of sac is formed by this cecum and ascending colon. So posterior wall of sac is formed by the viscera, and this is known as what? Sliding hernia. It is also known as hernia inglicid. So what's the name of this hernia? This is known as hernia inglicid, and the common name which we use, it is also known as what? Sliding hernia. Sliding hernia. So what is the special feature in this sliding hernia? That posterior wall of sac is formed by the viscera. So in this case, posterior wall of sac is formed by viscera. Simple. Generally this sliding hernia is more common in males, and generally it is more common on left side. So which part of large bowel is mobile on left side? It is the sigmoid colon. So the most common content is sigmoid colon. So here the posterior wall of sac is formed by the viscera. Now this sliding hernia is more common in males and it is more common on left side. Which part of large bowel is mobile on left side? It is the sigmoid colon. So overall, what's the most common content of sliding hernia? It is the sigmoid colon. And if we are talking on right side, what is the most common content on right side? It's the cecum. So important point, that this hernia inglicid, it is more common in males and it is more common on left side. So that's why what's the most common content? And the most common content is the sigmoid colon. It's the sigmoid colon. But specifically in the question, if it is mentioned that what's the most common content on the right side, so on the right side the most common content is the cecum. Clear? What is the problem? If you remember how we perform the hernia surgery, generally one of the step in hernia surgery is what? We apply the purse string suture. So see, if we are not going to open the fundus and if we are not going to visualize the content inside, blindly if we are applying the purse string suture and we are going to cut the structure, what you are going to injure? You are removing the sac, simultaneously you are also removing what? Part of bowel. So there is high risk of bowel injury if the surgeon is not very careful. So in such cases, how we perform the treatment? See, whenever we are going to notice that this patient is having what? Sliding hernia, here the organ along with the sac, means the sac and the content. The sac and content is inverted back to the peritoneal cavity, and when this sac and content is inverted back, then we are going to close the defect. So what's the problem here? There is increased risk of bowel injury or complications during hernia repair. Simple. And that's why what's the treatment? Treatment is invert the organ with sac. So sac with content is reduced back and the defect is closed. So here sac with content, it's reduced back, clear, and close the defect. Right? So this is how we treat the sliding hernia, which is also known as hernia inglicid. Now tell me the diagnosis. In this case, can you see there is hernia in the lumbar region of posterior abdominal wall? So what is the name of this hernia? This is lumbar hernia, and you can see it is more common on which side? It is more common on left side. So this is lumbar hernia. It's lumbar hernia. Clear? And in this case, what's the location of hernia? There is herniation in the lumbar region. So in these patients, there is herniation in lumbar region of posterior abdominal wall. In lumbar region of posterior abdominal wall. Clear? It is more common on left side. It can be congenital or acquired. In 20% cases it is congenital, and in 80% cases it is acquired. Okay, so it is more common on left side. It can be congenital. So in how many cases? Congenital in 20% and acquired in 80% cases. Clear? Now see, in relation to lumbar hernia, there are two triangles. One is known as superior triangle of Greenfeld and another is known as inferior triangle of Pettit. Most of lumbar hernias are going to occur via superior triangle of Greenfeld. But in Bailey it's written that most of the hernias are occurring via inferior triangle of Pettit, which is wrong. Now see, this is Bailey. And what is written in Bailey? You can see most primary lumbar hernia occurs through inferior lumbar triangle of Pettit. Clear? This is wrong. See what's written in Shackelford, which is the Bible of GI surgery. So this is the Shackelford, and this is what is written. Herniation occurs more commonly in superior triangle as it has greater surface area. Clear? So what you are going to mark in the exam, that in lumbar hernia, most commonly the herniation occurs via superior triangle of Greenfeld. Okay. Second question which is asked nowadays, it's the boundaries of superior triangle of Greenfeld and inferior triangle of Pettit. Now see this diagram. Here you can see that in the paravertebral region there is paraspinal muscles. So there is paraspinal muscle, and you can see this rib. What is this rib? This is 12th rib. And you can see this muscle. So anteriorly, which muscle is there? Internal oblique. So what are the boundaries? Anteriorly there is internal oblique, posteriorly there is paraspinal muscle, and superiorly there is 12th rib. These are the boundaries of superior triangle of Greenfeld. So see the boundaries: superior triangle of Greenfeld, superior triangle of Greenfeld. What are the boundaries? Anteriorly there is internal oblique, posteriorly there is paraspinal muscle, and superiorly there is 12th rib. Now coming to the inferior triangle of Pettit. So here you can see in inferior triangle of Pettit, anteriorly there is external oblique, and you can see posteriorly there is a large muscle. What's the name? Latissimus dorsi. So posteriorly there is latissimus dorsi, and if you see inferiorly, what? This is iliac crest. So iliac crest, it's located inferiorly. So see again, anteriorly external oblique, posteriorly latissimus dorsi, inferiorly iliac crest, and this is known as inferior triangle of Pettit. This is inferior triangle of Pettit. So superior triangle of Greenfeld, inferior triangle of Pettit. Most of the lumbar hernias occur via superior triangle of Greenfeld. Why? Defect is large. Now see, what you noticed in lumbar hernia, that the defect is very large, and any hernia which is having very large defect, which complication is rare? Strangulation. So because of large defect, these patients have very low risk of complications. Now what is the presentation? Sometimes patient is not aware that he is having lumbar hernia. So what? Patient comes to us and tells that, sir, I'm having bulge in the lateral abdominal wall, lumbar region of abdominal wall. So what's the presentation? Clinical features. There is unilateral bulge in the lumbar region. in lumbar region. Simple. And since there is large defect, what? Strangulation is rare. So because of large defect, strangulation, it's rare. Clear? So strangulation is rare because of large defect. Now how we are going to treat this patient? The name of surgery is Daud's operation. So it's unique name. What's the name of this surgery performed for lumbar hernia? It's Daud's operation. It seems that this operation is to catch Daud. So this is Daud's operation for lumbar hernia. Now we are going to discuss obturator hernia. What are the other names of obturator hernia? It is also known as skinny old lady hernia, also known as French hernia. So what are the other names? It is also known as skinny old lady hernia. It is also known as French hernia. So skinny old lady hernia, also known as French hernia. Okay, it is very easy to remember. See, you know that there is obturator canal. Okay, and in the obturator canal there is presence of obturator nerve and obturator vessels. So whatever the structure is there, generally that is obturator in relation to obturator hernia. So in obturator canal there is presence of obturator nerve and obturator vessels. Simultaneously there is presence of fat and ligaments. Simple. So what's the problem? Any patient in whom there is loss of fat because of rapid weight loss, chronic malnutrition, or there is laxity of ligament. So there is loss of fat, laxity of ligament, and third, increased intra-abdominal pressure. In all these cases, what will happen? There is herniation of bowel into obturator canal. And if bowel is going to herniate into obturator canal, obviously which nerve will be compressed? It's the obturator nerve. And obturator nerve is going to supply the medial aspect of thigh. So what is the symptom? Whenever this nerve is compressed, patient complains of pain over the inner aspect of thigh radiating to the knee joint. Clear? So see important points. First, what are the risk factors? So loss of fat. In which patients there is loss of fat? It's written. Can you see the risk factors are written here? Skinny old lady hernia. So what kind of patient? It is more common in males or females? Females. What kind of females? Elderly females. And the patients who are skinny means lean and thin. So first, lean and thin patient. Why? Because of chronic malnutrition. Elderly females. Multipara patients. Why? Because there is release of relaxin which is going to relax the ligaments. So multipara patients. And any patient in whom there is increased intra-abdominal pressure, especially the patients who are having chronic constipation. So especially the patients who are having chronic constipation, or any patient who is having increased intra-abdominal pressure. So because of this, what happens? There is herniation of bowel into the obturator canal. So here you can see how it looks like. You can see here that this is the obturator hernia sac. Clear? And you can see this is the part of small bowel which is herniated in the obturator canal. And because of this, there is compression of obturator nerve. So there are two important signs which are frequently asked in exam. One is known as Hauschip-Romberg sign. So because of compression of obturator nerve, there is pain along the inner aspect of thigh radiating to ipsilateral knee joint, known as Hauschip-Romberg sign. And the second is Hannington-Kiff sign. It's because of absence of obturator reflex. So what are the two important signs? See the clinical features. First, Hauschip-Romberg sign. Clear? Many times it was asked in NEET and DNB. So this is pain along inner aspect of thigh. Radiating to ipsilateral knee joint. It is radiating to ipsilateral knee joint. And the second sign which is asked, and that is Hannington-Kiff sign. So it's the Hannington-Giff sign. Clear? And what is seen here, in this case, because of compression of obturator nerve, there is absence of obturator reflex. So what happens? Absence of obturator reflex. Obturator reflex is a withdrawal reflex. Clear? So this is absence of obturator reflex. And how we are going to treat it? So we have to perform the repair via posterior approach. So see the treatment here. Repair is done by posterior approach. So this is how we manage the patients of obturator hernia. Here everything related to obturator hernia is obturator nerve, obturator vessels. So there is compression of obturator nerve, and because of that these clinical signs are seen. Now see what is the definition of umbilical hernia, paraumbilical hernia and epigastric hernia. So it's very easy to remember. If this is abdomen, you can see here that this is the abdomen and this is the umbilicus, right? So if hernia is occurring directly via umbilicus, it is known as umbilical hernia. So you can see hernia occurring directly via umbilicus, and this is what umbilical hernia. After that, hernia within 2 centimeter of umbilicus, either above, below, right or left. So hernia within 2 centimeter of umbilicus is known as paraumbilical hernia. So this is umbilical hernia and this is paraumbilical hernia within 2 centimeter of umbilicus. Now here you can see that this is xiphoid process, and from xiphoid process till 2 centimeter of umbilicus, from xiphoid process till 2 centimeter of umbilicus, if hernia is occurring, it is known as epigastric hernia. So this is what epigastric hernia, right? So these are the 3 definitions. Okay, one by one we are going to discuss. First we are going to discuss the epigastric hernia. What is the other name of epigastric hernia? It is also known as epigastric lipoma, and the other name is fatty hernia of linea alba. So what are the various names of epigastric hernia? So epigastric hernia is also known as epigastric lipoma. This is epigastric lipoma, and it is also known as fatty hernia of linea alba. Fatty hernia of linea alba, right? So we discussed that what's the location of this hernia. It's from xiphoid process till 2 centimeter of umbilicus, and here you can see where is the defect. It's mentioned here. The defect is there in the linea alba. So defect is in the linea alba, and there is herniation of what? See, fatty hernia. So there is herniation of pre-peritoneal fat. Clear? So it is characterized by defect. It is characterized by defect in linea alba. Okay, and there is herniation of pre-peritoneal fat. So herniation of pre-peritoneal fat. Okay, see this epigastric hernia in 20% cases it is multiple, and in 80% cases this is in the midline. So if you see the diagram, this is the diagram. This was the umbilicus, 2 centimeter, that is paraumbilical hernia, and from xiphoid process till 2 centimeter of umbilicus. So in 20% cases it is multiple, and in 80% cases it is in the midline. Clear? So it is multiple in 20% cases, and it's in midline. It's in midline in 80% cases. Now see the problem. There is a very small defect in the linea alba, and via this defect there is herniation of pre-peritoneal fat. And what is the problem? Since defect is very small, there is incarceration of pre-peritoneal fat. So because of this incarceration there is pain. And what happens? Because of this incarceration there is referred pain to epigastrium. And if there is referred pain to epigastrium, patient thinks that patient is having this pain because of peptic ulcer. So this question was asked many times, that which hernia mimics peptic ulcer, and it's the epigastric hernia. So see clinical features. Clinical features. So in epigastric hernia, there is referred pain. There is referred pain to epigastrium. And since there is referred pain to epigastrium, it mimics peptic ulcer. This is the question which is asked. It mimics peptic ulcer. Okay. Now how we are going to treat it? It's very easy. See, there is herniation of pre-peritoneal fat. Okay. So we are going to excise that pre-peritoneal fat, and the defect is very small. Generally we close the defect. But whenever the size of defect is more than 4 centimeter, in those cases generally we use mesh. So how we are going to treat the epigastric hernia? We perform excision of pre-peritoneal fat. Excision of pre-peritoneal fat plus repair of defect. Repair of defect. So generally we are going to close the defect with the help of sutures only, and whenever the size of defect is 4 centimeter, in these cases we are going to close the defect and we have to use the mesh. So this is how we manage the patients of epigastric hernia. Now we are going to discuss umbilical hernia. So what is the definition of umbilical hernia? It's the hernia occurring directly via umbilicus. And paraumbilical hernia, hernia within 2 cm of umbilicus. Here you can see the picture of umbilical hernia. This is an infant and this is an adult patient. So an adult patient and an infant, and here you can see herniation directly via umbilicus. In infants, it is congenital, and in adults, it is acquired. So see what are the differences. If you're talking about the umbilical hernia in infants, this is congenital, and generally it is more common in Africans. So it's more common in Africans. And what is the good thing? That there is spontaneous resolution by 2 years of age. So this is going to close spontaneously by 2 years of age. So there is spontaneous closure. You have to remember the age. And this spontaneous closure occurs by 2 years. It occurs by 2 years of age. What happens in adults? In adults, it is acquired. And in which cases you are going to find the umbilical hernia? Any patient in whom there is increased intra-abdominal pressure leading to stretching of umbilicus. So you will find the cases of umbilical hernia mainly in the females. Why? Because these are multipara females. Especially which females? Multipara females because of pregnancy. And patients who are suffering from ascites. Which patients? What's the most common cause of ascites? Cirrhosis. So patients of cirrhosis which are having ascites, because of that also there is stretching. In adults, it is acquired. Clear? And what are the risk factors? It is more common in females, and risk factors are any condition in which there is increased intra-abdominal pressure. So in which conditions? Like we have seen pregnancy, multipara patients especially, and patients who are having ascites. What's the cause? Because of cirrhosis. And even in patients of obesity also. What? In obese patients also we are going to find the umbilical hernia. What is the good thing? Since there is stretching of umbilicus, so what happens over a period of time? The size of defect is going to enlarge. And since over a period of time there is stretching and the size of defect is going to enlarge, that's why the risk of complications are rare. So whether it is in infants or in adults, the risk of complications. So complications are rare. So it's rare. Okay. Now see, in all patients surgery is not required. So what are the indications of surgery in patients of umbilical hernia? Indications of surgery in patients of umbilical hernia. Okay. So generally we are supposed to wait for 5 years, maximum 5 years. We discussed that by 2 years usually spontaneous closure occurs. So maximum we are going to wait for 5 years. Even after 5 years, if there is no closure, we have to go for the repair. So if it persists beyond 5 years, so hernia persists beyond 5 years. Second, if the patient is having symptoms or if there is strangulation. So there is complications like strangulation. So symptomatic patient, if there is strangulation or if the size of defect it's more than 2 centimeter. So whenever the size it's more than 2 centimeter, and you are going to notice that there is progressive enlargement of hernia over a period of 1 to 2 years. So whenever there is progressive enlargement after 1 to 2 years, progressive enlargement after 1 to 2 years. Clear? Okay. And what about adults? Adult patients who are symptomatic and the adult patients who are going to develop any complications. In those cases, we have to perform the surgery. Now here also what principle is applied? If the defect is small, it is closed primarily. And whenever the size of defect is more than 3 centimeter, we have to close the defect and we have to apply the mesh. So how we treat umbilical hernia? Treatment. If there is small defect, so in cases of small defect, it is closed primarily. So this is closed primarily. Okay. And whenever there is large defect, you have to remember the size. Here, what is the size? More than 3 centimeter. So generally, the size of defect is 4 centimeter or more. And in these cases, we have to use the mesh. So we have to use the prosthetic mesh. There is another question which is frequently asked, but this procedure is rarely performed nowadays. That is known as Mayo's repair, and it is also known as vest over pant repair. So what happens? We are going to overlap the tissues and we are going to suture it. So because of this overlapping, there is increased tension over the tissues. And if there is increased tension, because of this tension, there is increased recurrence rate. That's why this Mayo's repair is rarely performed nowadays. So what's the name of this repair? It's known as Mayo's repair. And this Mayo's repair is also known as vest over pants repair. Vest over pants repair. Simple. What is the problem? Here, there is increased tension over the tissues because of overlapping, and because of this increased tension, there is increased recurrence rate, and that's why it is not performed usually. So this is not performed usually nowadays. Now see these pictures and tell me the diagnosis. These are two types of abdominal wall defects. If you see the first diagram, here what you can see, here you can see that this is the umbilical cord and there is herniation of bowel, but what else you can notice? That the bowel is covered. So in the first diagram, there is herniation of bowel, but it is covered by two layers. The outer layer is known as amnion and the inner layer, this is peritoneum. So what is the name of this condition? The first condition is known as omphalocele, also known as exomphalos. So in omphalocele or exomphalos, what you have noticed that there is herniation of bowel, but this is covered by two layers. Outermost is amnion and innermost is peritoneum. If you see the second condition, it is known as gastroschisis. And what happens in gastroschisis? There is splitting of abdominal wall. Now can you see, this is what umbilical cord. So you can see this is intact. This is the umbilical cord. On the right side of umbilical cord, means in the right abdominal wall, there is splitting. And because of this splitting, what you can see that there is herniation of bowel and this bowel is exposed. Clear? So see this picture. This is a picture of omphalocele, also known as exomphalos, and here you can see the exposed bowel because of splitting in the right side of abdominal wall, means it is located on the right side of umbilical cord. So first is omphalocele, second is gastroschisis. These are the image based questions being asked continuously from the last 3-4 years. So we are going to discuss in detail the omphalocele and gastroschisis. This is gastroschisis. Clear? So what happens in omphalocele or exomphalos? Here, intestine fails to return. Intestine fails to return to intra-abdominal cavity. It fails to return to intra-abdominal cavity and it is covered by 2 layers. What are those 2 layers? It is covered, so bowel is covered by 2 layers. The outermost is amnion and the inner layer is peritoneum. So it is covered by these 2 layers. Okay. Whenever the defect is small, there is herniation of only small intestine, and whenever there is large defect, apart from small intestine, there can be herniation of liver also. So if these patients are having small defects, in small defects, there is only herniation of small intestine, and if there is large defect, then there is herniation of small intestine and other organs like liver. Now see, this topic is also asked in pediatrics, and the question that omphalocele is associated with trisomies. Which trisomies? Trisomies 13, 18 and 21. So this is important question. It is associated with trisomy 13, 18, 21. The second important point which is frequently asked, that this omphalocele or this condition is associated with congenital malformations. And what is the most common type of congenital malformation seen? So here the most common type of congenital malformation is cardiovascular, followed by musculoskeletal, followed by gastrointestinal, followed by genitourinary. Okay, so it is associated with congenital malformations. You have to remember congenital malformations, and the most common congenital malformation is cardiovascular, followed by musculoskeletal, followed by gastrointestinal, followed by genitourinary. Okay, so how to remember? CM Gigu. It is the CM Gigu. Clear? Cardiovascular, followed by musculoskeletal, followed by gastrointestinal, followed by genitourinary. Now see the question related to congenital malformations, that what is the most common cause of death in patients of omphalocele, and it is the congenital malformations. So because of association with congenital malformation, the prognosis is poor in omphalocele as compared to gastroschisis. Okay, so the problem, this congenital malformation, it's the most common cause of death, and because of association of these congenital malformations, these patients have poor prognosis. When we were discussing the Wilms tumor, we discussed that there is one variant which is associated with omphalocele, and what's that variant? It's the Beckwith-Wiedemann syndrome. What are the other manifestations in Beckwith-Wiedemann syndrome? There is hemihypertrophy, there is visceromegaly, there is macroglossia, omphalocele and hepatoblastoma. So what is the other condition with which it is associated? It is associated with Beckwith-Wiedemann syndrome. Clear? These are the important points related to omphalocele. Now see the gastroschisis. So in gastroschisis, there is splitting of abdominal wall on right side with herniation of bowel. bowel. Okay, and what kind of this bowel is covered or exposed? So this bowel is exposed. And since this bowel is exposed, what's the problem? Here, the bowel is thickened, matted, and edematous. So because it is exposed, what's the problem? The bowel is thickened, it's matted, and edematous. It's edematous. Clear? And there is one association with gastroschisis, that it is associated with intestinal atresia. So what's the association? It is associated with intestinal atresia. Otherwise, the congenital malformations are not seen. So here, it is not associated with any other congenital malformation. So what are the risk factors? If mother has history of intake of alcohol, or there is history of smoking, history of intake of aspirin, brufen, pseudoephedrine, so all these are going to increase the risk. Second, if the age of mother is less than 20 years, it also increases the risk. So what are the risk factors? Risk factors for gastroschisis. Yes, so if there is intake of alcohol, female patient, or the mother was a smoker, or there was intake of aspirin or brufen, or intake of pseudoephedrine, if there is history of intake of pseudoephedrine. Clear? So these are the risk factors. How to remember is very easy. The mnemonic is ASAP, as soon as possible. Alcohol, smoking, aspirin, pseudoephedrine. Another risk factors which we discussed, that if the age of mother is less than 20 years, yes, this is also a risk for gastroschisis. Now, if you see the picture, in gastroschisis, the bowel is exposed. So it gives impression that if the bowel is exposed, there is increased risk of complications, so prognosis must be poor. But what's the good thing? That this is generally not associated with congenital malformations which were responsible for death in omphalocele. So if we are going to compare the prognosis with omphalocele, relatively it is better. So in gastroschisis, relatively prognosis is better. So here, prognosis is better. So prognosis, it's relatively better as compared to omphalocele. Now we are going to discuss incisional hernia. And what is the other name of incisional hernia? It is also known as postoperative ventral wall hernia. So what's the other name? It is also known as postoperative ventral wall hernia. Ventral wall hernia. Now the term is self-explanatory. This hernia is occurring after surgical incision. Okay, so after surgery, if this hernia is occurring, this is known as incisional hernia. And what is the problem? After surgery, when we are going to repair the tissues, and whenever there is failure of fusion of facial tissue, because of failure of fusion of facial tissue, what happens? This hernia occurs. How it looks like? Now see, this is how it looks like from outside. So here, can you see that this is the incision? This is the incision, and can you notice the swelling? And if you see the inside, here you can see that there is intact skin. Clear? So there is intact skin and the content is beneath the skin. What is the problem? Here you can see that this is the hernia defect, and via this defect there is herniation of this bowel. How it is going to occur? See, whenever we are going to perform the laparotomy, we are going to close the abdominal wall usually in 3 layers. How we close? See, this is the rectus muscle. Clear? This is the rectus muscle. Around the rectus muscle, you can see that there is rectus sheath. Okay, so we have to close the rectus sheath. How we close the rectus sheath? Generally, we close the rectus sheath with proline. So we are going to close it with proline. After that, there is subcutaneous tissue. So this is the subcutaneous tissue, And this subcutaneous tissue, generally it is sutured with vicryl or catgut. So this subcutaneous tissue is sutured with vicryl or catgut, and then there is skin, and we are going to close the skin with silk. So this is how we close the laparotomy. So abdominal wall is closed in 3 layers. What's the problem? See, sometimes suppose the sutures are going to break, or there is separation of this facial tissue because of anything, because of increased intra-abdominal pressure. So what happens? This facial tissue is not going to fuse, and via this defect, what happens? There is herniation of bowel. So what happens? There is failure of fusion of facial tissue leading to herniation of bowel. So here you can notice that this is the rectus. You can see this is rectus. This is rectus sheath. Clear? And there is failure of fusion, and that's why what happens? There is protrusion of bowel. Now, one simple question. So in which incisions there is increased risk of incisional hernia? So first, in long incision there is increased risk, or short incision, so obviously long. In midline or paramedian, so obviously in the midline. In transverse or vertical, so obviously in vertical. And in upper abdominal or lower abdominal, so obviously in the lower abdominal. So in which incisions there is increased risk of incisional hernia? So if patient is having long, midline, vertical, long, midline, vertical, lower abdominal incision. Clear? So these kind of incisions are having increased risk of incisional hernia. Apart from these risk factors, there are 3 other risk factors. One is surgery related, one is surgeon related, and the third is patient related. So see the risk factors. There are 3 groups of risk factors. First, surgery related. Second is surgeon related. And the third is patient related. Okay. You have seen that we can either perform elective surgery or emergency surgery, and you know there is increased risk of complications after emergency surgery. So there is increased risk of incisional hernia obviously after emergency surgery, and the patients who have post-operative complications or who developed post-operative complications like wound infection, in those cases also there is increased risk. So surgery related, generally it is seen in which surgery? It is more common in emergency surgeries, and if there is post-operative complication. So patient developed post-operative complication like burst abdomen, like wound infection. So if there is wound infection, there was burst abdomen. Clear? Surgeon related. Suppose the surgeon's skill is not good, surgeon technique is poor, surgeon used absorbable sutures for closing the facial tissues, or there is closure under tension. So if there is poor technique of surgery, closure was done under tension, so closure under tension. And very important risk factor, if there is use of absorbable sutures by mistake for facial tissue. So use of absorbable sutures. Clear? Patient related factors. Now see, any condition which impairs wound healing and patient is suffering from that increases the risk of incisional hernia. And you must be knowing what's that one risk factor which is very, very important, and you will find it commonly: diabetes mellitus. So what are the factors which are going to impair the wound healing? Factors leading to impaired wound healing like diabetes mellitus, immunocompromised patient, or HIV positive patient. If there is steroid intake, patient is taking steroids, or there is decreased protein synthesis or some systemic illness, so patient is suffering from jaundice, there is ascites, or patient is having cirrhosis. Clear? So all these are the risk factors for incisional hernia. In INI CET 2020, for the first time, there was one question related to EHS classification of incisional hernia. EHS full form is European Hernia Society classification. This was asked for the first time. See what was the question. Now see the chart of European Hernia Society classification for incisional hernia. So it is divided into two types. Either it can be midline or lateral. Midline is further divided into 5 types, M1 to M5, and the lateral incisional hernias are divided into 4 types, L1 to L4. Okay, so M1, that is subxiphoidal, located in subxiphoidal region. If it is located in epigastric region, this is epigastric, umbilical, infraumbilical and suprapubic. Similarly, the lateral incisional hernias are divided into 4 types, L1 to L4. L1 is subcostal, L2 is involving the flank or present in the flank, L3 is present in the iliac region, and L4 if it's located in the lumbar region. This is the classification. Then in the chart it is mentioned whether this incisional hernia is recurrent or not. So whether it is recurrent or not, and you have to mention what is the length and what is the width. Now see the diagrammatic representation. So this is midline and this is lateral. Okay, so what is M1? It is subxiphoidal. M2, that is epigastric. M3 is umbilical. M4 infraumbilical, and M5 this is suprapubic. Okay, so how to remember? The mnemonic is CU in suprapubic region. So CU in suprapubic region. Clear? This is M1, this is M2, this is 3, this is 4, this is 5. Okay, so this is subxiphoidal. E, that is epigastric. U, it's umbilical. IN, this is infraumbilical, and suprapubic is suprapubic. Clear? So 1, 2, 3, 4, 5. M1, M2, M3, M4, M5. Which was asked in INI CET M3. This was asked in INI CET 2020. Now coming to lateral. Okay, so lateral L1, you can see it is subcostal. Involving flank, it is L2, and if it's involving this iliac region, it is L3, and if it is involving this lumbar region, it is known as L4. So how to remember? Here also there is a mnemonic, and the mnemonic is subfill. Okay, this is L1, L2, L3, L4. So what is L1? Subcostal. Fill, F means flank, I means iliac, and L means lumbar. So you have to remember, since it was asked in INI CET, we are expecting this question in NEET PG. Now coming to the treatment of incisional hernia. One simple question, that in incisional hernia, which surgery should be preferred, laparoscopic or open? So laparoscopic repair is preferred or open? So obviously we are going to prefer laparoscopic surgery or laparoscopic repair. Why? Because if you go for open approach, there is extensive tissue dissection, and if you go for extensive tissue dissection, what's the problem? Because of increased tissue dissection, there is weakness, so there is increased risk of recurrence. That's why laparoscopic repair is preferred. And what's the gold standard treatment for incisional hernia? It is IPOM. So what's the treatment? The gold standard treatment for incisional hernia, and it's IPOM. What is the full form of IPOM? It is intraperitoneal onlay mesh repair. It is the intraperitoneal onlay mesh repair. So the full form is intraperitoneal onlay mesh repair. Clear? Generally we get a case of incisional hernia in final year or in surgery third year exam. right? And whenever you are going to tell the examiner that, sir, I want to go for IPOM, intraperitoneal onlay mesh repair, in the viva, immediately examiner is going to ask you what is onlay, what is overlay, what is inlay, what is interlay, and what is sublay or underlay. So it is very easy to understand. See, whenever we are going to close the sheath, and after closing the sheath, if we are putting the mesh above the sheath, so after closing the sheath, if you are putting the mesh above the sheath, this is obviously onlay or overlay. Sometimes it's difficult for you to close the sheath, so when you are going to suture the mesh to edges of the sheath, this is known as inlay in between, inlay or interlay. And whenever we are placing the mesh below sheath, first we place the mesh and then we close the sheath. So if it is placed below, this is known as sublay or underlay. Okay, so see, imagine that this is the sheath. We are going to close the sheath, and after closing the sheath, you are putting the mesh above sheath. So this is onlay or overlay. This is onlay or overlay. If we are putting the mesh below sheath, so this is sublay or underlay. Sublay or underlay. And third situation, whenever it's not possible for you to close the sheath, sometimes it's not possible, then we are going to suture the mesh to the edges of sheath. So suture the mesh to the edges, and this is known as inlay or interlay. Inlay or interlay. So I'm repeating: close the sheath, after closing it, putting mesh above sheath, onlay overlay, below sheath, sublay underlay, in between the sheath, inlay interlay. But what is the gold standard treatment? It is intraperitoneal onlay mesh repair. What is the problem with incisional hernia? That there is high risk of recurrence. But if you go for IPOM, it is going to decrease recurrence rate by more than 50%. So it is going to decrease the recurrence rate by more than 50%. That's why it is gold standard for incisional hernia. Now we are going to discuss desmoid tumors. In desmoid tumors, first we are going to discuss the distribution. So see, in 60% cases it is extra-abdominal, and in 25% cases it is arising from abdominal wall, and in 15% cases it is intra-abdominal. Okay, so first see the distribution of desmoid tumor. So in 60% cases this is extra-abdominal. So this is extra-abdominal. In 25% cases, it is arising from abdominal wall. And in 15% cases, this is intra-abdominal. In 15% cases, this is intra-abdominal. Simple. Here, we are going to discuss the abdominal wall desmoid, and this question was asked in AIIMS. So we are going to discuss the abdominal wall desmoid tumors. Abdominal wall desmoid tumors. Okay. Now see what is the location generally. Generally it is infraumbilical, and it arises from musculo-aponeurotic structures. What are the risk factors? Previous surgery or history of surgery is a risk factor. So surgical incision is a risk factor. How this tumor looks like? Have a look. Abdominal wall desmoid. This patient had surgery. After surgery, this patient developed this kind of lump, and it was a tumor. Can you see the location? It is infraumbilical. So what is the location of abdominal wall desmoid? It is infraumbilical. First important point. And it's going to arise from musculo-aponeurotic structures. So it arises from musculo-aponeurotic structures. Okay. Musculo-aponeurotic structures. Generally these tumors are not capsulated or unencapsulated. So since the tumor is unencapsulated, when we are trying to cut the tumor, it cracks. So the tumor is unencapsulated. That's why tumor cracks when we attempt to cut the tumor. See the risk factors. So we discussed what are the risk factors. History of previous surgery or trauma, surgical trauma. So history of previous surgery or trauma. Another important point related to this tumor, that estrogen promotes the growth of tumor. Right? So if estrogen stimulates the growth of desmoid tumor, it is more common in males or females. So obviously it is more common in females. Why? Because estrogen stimulates the growth. When we were discussing FAP, familial adenomatous polyposis, we discussed one variant of FAP which was autosomal dominant associated with desmoid tumor, and what was the name? It was Gardner syndrome. So third risk factor, it's the Gardner syndrome. It's a variant of FAP and it is associated with desmoid tumor. So these are the risk factors. Now see, desmoid tumor is arising from musculo-aponeurotic structure. So it is arising from soft tissue. So it behaves like soft tissue sarcoma. But all features of soft tissue sarcomas are not seen, like that in this tumor it is just like a soft tissue tumor, but here there is no sarcomatous change and there is no distant metastasis. Important properties: no sarcomatous change and no distant metastasis. But what is the problem? This tumor is going to infiltrate the muscle in surrounding region, and if tumor infiltrates the muscle in surrounding region during excision, if wide margin is not being taken, what happens? There is local recurrence. Clear? Just like soft tissue sarcoma, what is the investigation of choice for diagnosis? It is biopsy. And what is the investigation of choice to assess the extent of tumor? And that's MRI. And like soft tissue sarcoma, what's the treatment? It's the wide local excision with 2 cm margin. Clear? So see, special properties which differentiates it from soft tissue sarcoma, that here there is no sarcomatous change. In this tumor, no sarcomatous change and no distant metastasis. No distant metastasis. What is the problem? There is increased risk of local recurrence. What kind of? Local recurrence following excision. Why? Because it is going to infiltrate the surrounding muscle. What was the question in AIMS? That what is the most common presentation of desmoid tumor? Can you see? Obviously it's the abdominal lump or mass. So clinical features, most common presentation, and the most common presentation, it's the lump or mass. This was the question in AIMS. Now how we are going to make the diagnosis? It's simple. So investigation of choice for diagnosis, it's the biopsy, and investigation of choice to assess the extent, for assessing the extent, and for extent it's the MRI. Simple. And treatment is also like soft tissue sarcoma. So what's the treatment? We go for wide local excision with 2 cm margin. Okay. Now see, in exams 2 questions are asked. First, what is the treatment of choice for desmoid tumor? And that is wide local excision with 2 cm margin. And the second question which is asked, what is the treatment of recurrent desmoid? So treatment of choice for recurrent desmoid, and in that case we go for surgery, and with surgery we give radiotherapy. So if there is recurrent desmoid, so for recurrent desmoid the treatment of choices is the surgery plus radiotherapy. So you have to remember that if desmoid tumor is given in the question, treatment is wide local excision with 2 cm margin or only surgery. If it's recurrent desmoid, in that case only with surgery we give radiotherapy. Now see the named hernias. These are one-liner questions which are frequently asked. First, Gibbons hernia. What is Gibbons hernia? It is hernia plus hydrocele. So what is Gibbons hernia? Gibbons hernia, it's the hernia plus hydrocele. Okay. Second is Burgess hernia. Burgess hernia, it is hernia into pouch of Douglas. So what is Burgess hernia? Burgess hernia, it is hernia into pouch of Douglas. Into pouch of Douglas. After that, Beclard's hernia. In this case, there is hernia through saphenous opening. So Beclard's hernia. Beclard's hernia. It's the hernia through saphenous opening. You have to remember, hernia through saphenous opening. Next is Ogilvy's hernia. If you remember, we discussed Ogilvy's syndrome in intestinal obstruction. What is Ogilvy's syndrome? It is idiopathic colonic pseudo-obstruction. And this is Ogilvy's hernia. Here, there is hernia through defect in conjoint tendon. So Ogilvy's hernia. Ogilvy's hernia. It is hernia through defect in conjoint tendon. There is defect in conjoint tendon. There are two hernias which are commonly asked. One is Stammer's hernia and the second is Peterson hernia. What is Stammer's hernia? See, whenever we are performing retrocolic gastrojejunostomy, retrocolic means behind transverse colon, via transverse mesocolon. If we are not going to close this defect in the transverse mesocolon, there is herniation of bowel via mesocolon after retrocolic gastrojejunostomy. This is Stammer's hernia. So first see, what's the Stammer's hernia? Stammer's hernia. It is hernia through transverse mesocolon. Okay, after retrocolic gastrojejunostomy. RCGJ, retrocolic gastrojejunostomy. Second, Peterson hernia. One question which was asked previously in AIIMS, that what is the most commonly performed bariatric surgical procedure worldwide, and it is RYGB, Roux-en-Y gastric bypass. Roux-en-Y gastric bypass is the most commonly performed bariatric surgical procedure. In Roux-en-Y gastric bypass, if there is herniation of bowel beneath the roux limb, so if herniation occurs beneath the roux limb, this is known as Peterson hernia. This was asked in NEET PG many times. So what is Peterson hernia? Peterson hernia, in this case, there is hernia behind roux limb. Hernia behind roux limb. This is how we write roux limb after RYGB. What is the full form of RYGB? This is Roux-en-Y gastric bypass, and this is the most commonly performed bariatric surgical procedure worldwide. Now see this diagram for better understanding of three hernias. One is known as Velpu's hernia, that's known as prevascular. See the location? It is prevascular, means it is located in front of femoral vessels. Can you see? This is femoral vein and this is femoral artery. So it is located in front. This is Velpu's, also known as prevascular. Second, you have to remember this Serafini's hernia. Serafini's, it's retrovascular, means it is located behind femoral vessels. And third is Hasselback's hernia. If you see this Hazelback's hernia, this is femoral artery. So this Hazelback's hernia is located lateral to femoral artery. Okay. So Velpu's hernia, also known as prevascular, it is located in front of femoral vessels. Located in front of femoral vessels. Clear? This is Serafini's, it is retrovascular. This is located behind femoral vessels. It's located behind femoral vessels. And Hazelback's hernia, it is located lateral to femoral artery. So the location, it is located lateral to femoral artery. And we already discussed Logius and Cloquet. These were the variants of which hernia? These were the variants of femoral hernia. There is another hernia which is asked, and that's Holthaus hernia. Holthaus hernia. Holthaus hernia, it's a type of inguinal hernia in which there is extension of bowel along the inguinal ligament. So it's a type of inguinal hernia. Type of inguinal hernia. Clear? And in this case, what happens? There is extension of bowel along inguinal ligament. So there is extension of bowel along inguinal ligament. Clear? So these are the one-liner questions related to inguinal hernia. There is a special type of hernia in which there is herniation of part of circumference of bowel, and this is known as Richter's hernia. So here you can see this is the bowel, and you can see there is herniation of part of circumference of bowel. So in this case you will see that the sac contains only part of circumference of bowel. And what's the name of this hernia? It's known as Richter's hernia. Richter's hernia. Okay, and generally this Richter's hernia is most commonly associated with which type of hernia? The hernia which is having very high risk of strangulation because the canal and ring is narrow and rigid. We discussed that's femoral hernia. So the most commonly it is associated with femoral hernia. So see what's the problem here? In this case there is herniation of part of circumference of bowel. Part of circumference of bowel. So sac contains only part of circumference of bowel. Okay, now see, suppose this is the proximal part of bowel and this is the distal part of bowel, right? And what is the direction of peristalsis? This is the direction of peristalsis. So whenever there is herniation of part of circumference of bowel, the bowel is going to sense the obstruction. When bowel senses obstruction, bowel starts doing hyperperistalsis. Because of this hyperperistalsis, the patient will be having colicky pain. But since there is partial obstruction, what happens? The contents are going rapidly from proximal to distal direction. So from proximal to distal, rapidly the content is going. And that's why what will happen? These patients are having diarrhea. So two features. Two special clinical features, that patient is having hernia, but these patients have colicky pain and these patients have diarrhea. And whenever these patient comes to emergency, interns or whatever the resident is there, on the basis of clinical presentation, symptoms, the diagnosis of acute gastroenteritis is made. So it mimics which condition? It mimics acute gastroenteritis. And if it mimics acute gastroenteritis, what's the problem? There is delay in diagnosis. And if there is delay in diagnosis, there is increased risk of strangulation. So there is delay in diagnosis, and because of this, there is increased risk of strangulation. So these are the important features or important point related to Richter's hernia. So this is all about hernia.